Good evening, folks. I now call this meeting of the Standing Order Committee on Accountability and Oversight to order. My name is Steve Norn, and I am MLA of Tune the Willita and also chair of the committee. So members and viewers that are joining in with us, this is our first committee of the new year, and I wish to tell everyone Happy New Year, and welcome back. Today, members of the committee are joining us in person, by phone, and by video while they continue to physically distance to help reduce the spread of COVID-19. And just so everyone is aware, tonight's meeting is being broadcast live and is being live streamed on the Assembly's social media channels. And any public presentation materials can be found on our website. Committee will be hearing from the Honourable Julie Green, Minister of Health and Social Services, and Dr. Cami Candola, Chief Public Health Officer, about the rollout of the COVID-19 vaccine. Our first order of business is to open our meeting with a prayer, and I'll ask Emily Marcellos to offer the prayer.
Good evening, and the prayer I chose this evening is by Mother Teresa, because it's only common that she was always worried about the sick and the people that were sick around her, and she looked after the poor. So I think this is only reasonable. Anyway, people are very often unreasonable and self-centered. Forgive them anyway. If you are kind, people may accuse you of selfish, alternative motives. Be kind anyway. If you are successful, you will win some unfaithful and some genuine enemies. Succeed anyway. If you are honest and sincere, people may deceive you. Be honest and sincere anyway. What you spend years creating, others could destroy overnight. Create anyway. If you find serenity and happiness, some may be jealous. Be happy anyway. The good you do today will often be forgotten. Do good anyway. Give the best you have, and it may never be enough. Give your best anyway. In the final analysis, it is between you and God. It was never between you and them anyway. Amen.
Masicho Emily Marcellos. Our next item is the review and adoption of the agenda. There is one item on the agenda. Can I have a motion to approve the agenda as presented? Emily Cleveland has moved adoption of the agenda, and the motion is in order. All those in favor? All those opposed? Motion is carried. Having reviewed and adopted the agenda, are there any declarations of conflict of interest? We'll do as and when. So now we'll move on to our first public matter. And good evening, Minister Green. Before you begin your opening remarks, I'd just like to discuss how this meeting will proceed. And as we usually do, all comments, questions, and remarks will need to be directed to the chair. And both members and witnesses will need to wait to be recognized by the chair before speaking. And with that, Minister Green, the line is yours.
Yeah, thank you very much, Mr. Norn, and Happy New Year, colleagues. I'm here this evening to talk about the vaccine strategy and to provide you with an overview of that, and I appreciate the opportunity to do that. So joining me in this room on the 7th floor of the Tatsutine building, to my left is Dr. Cami Candola, the Chief Public Health Officer. Behind her is Kate Sills, the Special Advisor to the Deputy Minister. And behind me is my Special Advisor, Susan Laramie, and Carter Sterling, Special Advisor to the CPHO. And new to the table, our new Territorial Medical Director, Dr. Anne-Marie Pegg. And then, of course, on the phone is Bruce Cooper, the Deputy Minister of the Department. Mr. Chair, before I get to the strategy, I'd like to thank all of the staff who worked throughout the holidays to complete the strategy and begin implementing it. We began administering vaccines on December 31st, almost 2 weeks ahead of what we thought we would be doing. Our teams worked at incredible speed to vaccinate residents and staff at Avens in Yellowknife, at Jimmy Erasmus Senior's home in Betchco, And yesterday, vaccines were offered at the Extended Care Unit at Stanton Territorial Hospital. I'm proud to share that as of today, we've provided 162 first doses of that vaccine to residents and staff. Mr. Chair, I know the question on everyone's mind is, when will I get vaccinated? It's worth saying again that this is the most ambitious vaccine program we have ever delivered. We are trying to reach 26,000 people across 33 communities in the next 3 months. Not only that, but we are also taking into account the vaccine's complex cold chain requirements, the logistics of delivering 2 doses to all communities, and the fact that the weather in the middle of winter is often unpredictable. The vaccination strategy I'm here to present tonight provides a roadmap for this work. It reviews what we know about the Moderna vaccine right now and why we are comfortable providing it to residents. The strategy also reviews how we will communicate with residents about the vaccine so that they can make an informed choice to get vaccinated, and how we will consult with Indigenous and community leadership about the logistics of visits by traveling teams. It also identifies specific priority groups who will be first in line for the vaccine over the coming weeks. Dr. Candola will review the strategy in more detail in her presentation, but I want to spend a few minutes explaining what we mean by priority populations. These are people who are 60 or older, and the reason for that age cutoff is because of the severity of COVID-19 symptoms that increase with age. Other priority groups include those who have existing chronic disease and multiple medical conditions, those who frequently travel outside of the NWT to access medical care, those who may have an increased likelihood of transmitting COVID-19 to those who are at high risk of severe illness and death, and then finally those who are resident workers in the NWT but who regularly work out of the territory or at work camps with out-of-territory workers. Mr. Chair, I will now turn to how we are implementing this strategy. Vaccination teams will be at long-term care facilities in Fort Simpson, Fort Smith, Inuvik, Hay River, and Norman Wells this week. Mr. Chair, our next step is to reach some of the smallest communities at highest risk for community outbreak and highest risk of having COVID-19 imported from outside the NWT. The week of January 11th, we will focus on remote communities with health cabins, fly-in-only communities without winter road access, and border communities near a hub or regional center. In those communities, we will offer the vaccine to all eligible residents 18 years of age. After that, we will move on to vaccinate priority populations in small communities with road access. In February, we will move on to priority populations in regional centers. We expect to cover all of the priority populations between January and February of this year, so that in March, we can offer vaccines to the rest of the eligible adult population. If anyone is unable to make a vaccine clinic the first time we come to their community, we will make sure there is another opportunity for them to be vaccinated. Remember, each person requires 2 doses of the vaccine, so we will be making multiple trips to each community. Mr. Chair, the ultimate goal of our vaccine program is to provide the COVID-19 vaccine to as many eligible residents as possible in 2021. We want this strategy and implementation to create immunity in our communities. As we finalize dates and times of vaccine clinics, we will share this information far and wide. We have developed a flexible communication strategy that focuses on providing up-to-date information through traditional and new media in as many official languages as possible. The public can expect to receive information about the vaccine online, on paper, on the radio, on screen, and in person at our vaccine clinics. Although this rollout is much more complex than our typical flu vaccine program, vaccine delivery is not new. We have local staff with lots of experience to lead this work across the territory, including interpreters, healthcare providers, and community leaders. In closing, Mr. Chair, the bottom line is that residents will get as much notice as possible that the vaccine is coming to their community, and we will support them to make an informed decision when it does. We ask for residents' understanding if whether delayed vaccine shipments or cold chain management complications require us to adjust our plans. We will do everything in our power to ensure this vaccine delivery is as efficient, effective, and equitable as possible. I'll now turn this over through you, Mr. Chair, to Dr. Candola and ask her to walk us through the PowerPoint presentation. Thank you.
Yeah, Minister Green. Dr. Candola, line is yours.
Thank you, Chair. So I'll be providing an overview of the Community for Our Communities NWT COVID-19 vaccine strategy. Next slide, please. The overall goal of the strategy is to provide the vaccine to all eligible NWT residents in a safe but timely manner. This will help reduce the overall impact of COVID-19 and protect our most vulnerable populations. Next slide. The strategy is built upon 5 core values that are reflected through the rollout. Number 1, equity. All eligible adult residents will have access to the COVID-19 vaccine in a way that considers individual and community level risk factors. Number 2, cultural competency. Information and vaccine delivery will respect and adapt to the needs and context of the diverse people living in the Northwest Territories. Throughout our pandemic response, we have recognized the historical experiences and the ongoing impacts of colonization, cultural oppression, and systemic racism that impacts health outcomes and trust in the healthcare system. We will rely on existing relationships grounded in trust and mutual respect within our communities to ensure relevant, meaningful vaccine delivery and communication with the local and cultural context. Number 3, evidence-based decision-making. Decision-making of COVID-19 vaccine use in Canada will be based on science, independent regulatory review, and the advice of medical and other experts. And that includes the National Advisory Committee on Immunization. This reflects the fundamental importance placed on public health expertise, the independence of scientific research, and reliance on data and evidence regarding vaccine safety and efficacy. Reported from local and national sources will inform our processes and recommendations as we move forward. Number 4, flexibility and responsiveness. New information on vaccine products, distribution, and other logistical details are expected in the coming weeks and months. The NWT COVID-19 vaccine strategy sets the framework by which vaccines will be distributed. At the same time, the strategy will be responsive and flexible as new information arises and the rollout unfolds. And finally, number 5, trust. Trust is the foundational component to vaccine decision-making. To support vaccine decision-making at an individual level, residents need to trust the information they are receiving, as well as the recommendations from healthcare professionals and the institutions delivering the vaccination program. The need to promote public trust is an underpinning value in every action and decision of this vaccine rollout. These core values will help guide the delivery of a successful vaccine program in a manner that is most appropriate for Northerners. Next slide. So what do we know right now? The vaccine is publicly funded, which means that all eligible adult residents 18 years of age and older will be offered the vaccine free of charge. Like other vaccines, Northerners will be able to choose whether or not they want the vaccine. However, we strongly encourage all eligible adult residents to become immunized to protect themselves and others against COVID-19. As you know, we will be receiving the Moderna vaccine initially. The first shipment arrived on December 28, 2020. The federal, provincial, and territorial governments made this decision together to acknowledge the storage and handling complexity of the two initial vaccine candidates. While the Moderna vaccine is less challenging to transport throughout the NWT than the other available COVID-19 vaccine, it will still pose transportation and cold chain management challenges for our remote and isolated communities. The Moderna is an mRNA or messenger RNA vaccine. mRNA vaccines teach our cells how to make a protein specific to the COVID-19 virus, which turns on an immune response inside our bodies. That immune response, which produces antibodies, is what protects us from getting infected if the real virus enters our bodies. The mRNA is active in the cell, but does not enter the space where genetic material is housed. It does not contact or impact the cell DNA. Evidence shows that the Moderna COVID-19 vaccine has 94.1% efficacy in preventing any COVID-19 illness and 100% at preventing severe COVID-19 illness at least 14 days after the second injection. The Moderna vaccine requires 2 doses given at least 28 days apart, which is about 4 weeks. It is essential to receive the second dose to achieve the vaccine's full efficacy. The greatest immunity is expected 14 days after the second dose of the vaccine. The NWT is expected to receive enough vaccine to immunize 75% of all eligible residents, 18 years of age or older, within the first 3 months of 2021. This generous initial allocation from the federal government recognizes the territory's limited healthcare system capacities and the vulnerabilities of our remote Indigenous communities. If more than 75% of the eligible adult population in NWT decides to get vaccinated, there will be more vaccines that will be available later in the year. The NWT did receive 7,200 vaccine doses in the first of multiple vaccine shipments on December 28, 2020. At this time, the vaccine is only approved for adults 18 years and older. NACI recommendations advise that the COVID-19 vaccine should not be offered routinely to the following populations, and they were excluded from the initial clinical trials until further evidence is available. However, if people would like the vaccine and are in one of these categories, they could contact their healthcare provider to discuss having the vaccine. These people include those who are immunosuppressed due to disease or treatment, individuals with an autoimmune condition, pregnant or breastfeeding, under 18 years of age. Next slide. So there are 4 key components to the NWT vaccine strategy. 1, communicate. 2, plan. 3, distribute. 4, monitor and report. It is important to note that as we move through each component of the strategy, that there will be continuous adjustments made to our approach as we aim to meet our objectives. For instance, there needs to be ongoing communication and updates for the public now that the vaccine distribution has begun. Within each component of the NWT strategy, we will aim to achieve specific objectives through a combination of actions. So I will now walk through the objectives and actions under each component. Next slide. Significant vaccine uptake is necessary in order to protect vulnerable residents and stop the spread of COVID-19 at the population level. To achieve this, we will need to instill confidence in the safety and efficacy of the COVID-19 vaccine and empower residents to make informed choices about getting vaccinated. We'll also need to provide timely, accurate, and relevant information to NWT residents on a regular basis. The following actions will be required in order to realize these objectives. First, we need to work with Indigenous government and community leadership to understand community needs and perspectives. I and other health system partners have met with and will seek ongoing guidance and feedback from Indigenous governments and community leaders to inform a culturally respectful rollout of the vaccine. Continued collaboration with communities will allow for a deeper understanding of residents' perspectives and how to tailor communications to meet their needs. Extensive work is also underway with leadership to ensure timing, communication, logistics, and ongoing support to meet the needs of each community. 2, we need to provide information to residents that is accessible and understandable in order to help them make informed decisions about vaccination. Accurate and understandable information is the foundation of any successful vaccine program. It forms the basis of healthy behavior and informed decision-making. And we are committed to delivering information in ways that are clear, easily understandable, and accessible to all residents to support informed choices about getting vaccinated. Communication about COVID-19 vaccine is being finalized in 11 NWT official languages where possible. All communication materials use plain language and a variety of methods specific to Northern audience. As of now, I believe we have translated vaccine information sheets and vaccine cards into 10 of the 11 official languages. A facilitated terminology workshop has been booked for next week to determine scientific and technological words that are new for COVID-19 and how to describe the words in Indigenous languages so that the translation can be standardized. We are also hoping to have the explainer video ready by end of week. And another video addressing vaccine hesitancy will be filmed next week. Nurses have currently reached out to community health center staff to assist with any needs for community radio station questions and answers. Number 3, keep residents up to date on rollout and changes to evidence on recommendations. Residents will be regularly informed of where and when they'll be able to access vaccinations using a variety of communication methods to ensure optimum access. The NTHSA website with upcoming vaccine dates and communities was posted on January 5th and will be updated as more information becomes available. Any changes to vaccine evidence or recommendations, including any potential impacts to the COVID-19 vaccine rollout strategy, will be shared with the public. We will closely monitor updates related to the delivery of COVID-19 vaccines and update our strategy as needed. Number 4, address vaccine hesitancy and barriers to vaccination. When a vaccine is available, or people delay or refuse to get vaccinated, it's often because they are not confident in the vaccine. It is not convenient to get the vaccine, or they do not see the importance of the vaccine. This is referred to as vaccine hesitancy. Vaccine hesitancy is complex and can stem from a variety of factors. It is important to acknowledge and understand the different reasons or barriers that may contribute to vaccine hesitancy. This understanding will allow for issues to be mitigated throughout the planning and rollout of the COVID-19 vaccine program. Vaccine hesitancy is a new public health threat, according to the World Health Organization. As we see less disease, people become more concerned about the extremely rare adverse reactions. And with internet and media, there's a lot of misinformation. This causes concern and hesitancy. And now we're seeing diseases that we have not seen for years reemerge because of this. Having a new vaccine with new technology will also cause people to be concerned and hesitant. Ensuring there's evidence-based information available so that people can make informed decisions, and ensuring that people have more than one chance to get the vaccine so they have time to make a choice, will help combat vaccine hesitancy in the NWT. Next slide. Slide 7. Fine, thank you. The rollout of the COVID-19 vaccine is one of the most complex in Canada's history. Successful distribution across the NWT hinges on the quality of planning and practice that takes place both initially and on an ongoing basis. There are a number of areas in which the GNWT Department of Health and Social Services, in the partnership with health and social service authorities and federal partners, are focusing their planning efforts. So these include transportation and delivery logistics, safety and security, education and training, data collection, reporting, and monitoring. The objective is to ensure that vaccines are distributed in a timely, appropriate, and efficient way while maintaining vaccine integrity. So we are committed to the following actions. Number 1, build on existing partnerships with communities and government. Successfully importing, shipping, and distributing COVID-19 vaccines requires several unique considerations. To ensure safe handling requirements are met, the GNWT is working closely with the federal government to ramp up its capacity to meet the logistical challenges of receiving and distributing the vaccines across the territory. Logistical planning is a collaborative effort primarily between the territorial health and social service systems and federal partners. So the Immunization National Operations Center for COVID-19, known as NOC, in collaboration with provinces and territories, they act as the federal coordinating center for managing vaccine distribution across Canada. NOC and the Joint Task Force North are supporting logistics planning and project management for vaccine rollout in the Northwest Territories. Interdepartmental collaborations as well as partnership with local healthcare providers and community leadership are being leveraged to ensure planning is relevant to the realities of each community. This approach includes identifying local barriers and strengths, including the availability of infrastructure and resources to support mobile vaccine clinics and effective communication. Second action is building on existing vaccine delivery expertise. What we do know is thousands of vaccines are delivered and administered each year in the Northwest Territories. This includes the annual flu clinics, as well as routine and specialized vaccines. So vaccine delivery and standing up vaccine clinics is not new. We have local staff with lots of experience to lead this work across the territory. And the NWT will use the lessons from the H1N1 pandemic vaccine rollout. This is where 63% of the NWT population was vaccinated in less than 2 months. Though uncontrollable variables exist, which may prolong the time it takes to administer the vaccine, we do aim to achieve a high overall uptake of the COVID-19 vaccine. Third action is to recruit and train additional staff. The Northwest Territories Health and Social Services Authority will deploy small mobile vaccine teams, and they are made up of 8 healthcare providers and support staff, and they will be deployed into communities. These teams will help the local healthcare staff, who are considered the experts in their communities. This approach requires recruitment of additional staff to assist, support local staff, and ensure core health programming can continue. All healthcare staff of the Northwest Territories are required to complete a specialized immunization program called the Education Program for Immunization Competencies before they can deliver vaccines. Many of the providers already have this training. However, the Moderna vaccine is a new type of vaccine, and additional training is required to ensure appropriate storage and handling. Prior to vaccine delivery, healthcare providers will participate in a learning session about past Indigenous experiences with illness and disease in the Northwest Territories, as well as strategies for delivering culturally safe care to support appropriate vaccine delivery. This training recognized that historical experiences with systemic racism and negative experiences associated with communicable disease have occurred in the past, and we aim to ensure that they are not perpetuated. Training will be completed this week, so mobile teams, vaccine teams are prepared to administer the vaccine later this week and next. Action 4, maintain the safety and security of residents, workers, and the vaccine product. So teams are working to ensure the mobile clinics follow public health order requirements laid out in the Emerging Wisely plan, and that appropriate mitigation measures are in place to protect residents and healthcare providers from spreading COVID-19 infection. Additionally, teams are working with a NOC to ensure that threats to vaccine safety, such as breaks in its cold chain, are minimized. And the fifth action, procurement and strategic position of resources. In partnership with the NOC, we have procured the appropriate supplies like specialized freezers and coolers to maintain the vaccine cold chain, and related supplies like syringes, sharp containers, alcohol swabs, and personal protective equipment, which is required for vaccine administration. We are working with centralized points of distribution to ensure accessibility to regions and efficient transportation within the Northwest Territories. Next slide. The NWT is in a fortunate position to expect enough vaccines to vaccinate 75% of their eligible adult population in the first 3 months of 2021. However, doses for the whole population will not arrive at the same time, nor is it possible to have enough nurses to put needles in arms all on the same day. Therefore, a phased approach is being prepared for vaccine delivery starting in January 2021 that prioritize residents who are at highest risk. As vaccine supply increases, vaccination will be expanded to the entire eligible population starting in March 2021. NACI has provided independent expert advice regarding priority populations for the early vaccinations. NACI's recommendations have been incorporated into NWT priorities while still reflecting the unique phase of the pandemic, geography, and population of the Northwest Territories. This approach will remain flexible and will be adapted based on evolving transmission patterns. So there are two guiding principles which will inform the NWT COVID-19 vaccine prioritization. And they include, number one, risk of severe disease from COVID-19, and number two, risk of importation of COVID-19. The risk factors of initial consideration for immunization include advanced age. So what we know is the risk of COVID-19 severity starts to increase after age 60, and we know that the most vulnerable in this category are those who live in long-term care facilities or shared living environments. Those with existing chronic disease and multiple medical conditions are also at increased risk of severity. So residents with conditions like chronic lung, kidney, or heart disease are at greater risk for experiencing the severe form of COVID-19 and its complications. And if they travel outside the NWT regularly for medical care, they're at even greater risk for acquiring COVID-19. Another risk priority category are those the likelihood of transmitting COVID-19 to those at high risk of severe illness and death. So this is another important consideration. This risk group may include frontline healthcare workers or those who provide care to those high-risk vulnerable populations. Another category are resident workers who live in the Northwest Territories who work regularly out of territory or at work camps with out-of-territory workers. They are at elevated risk of acquiring COVID-19 and then transmitting it to family, household members, or those in the community. And another high-risk category that is also being reflected with the NACI recommendations are those living in remote communities, and these include Indigenous communities with limited health infrastructure in comparison to larger centers. Due to having multiple vaccine delivery teams and utilizing local resources when appropriate, or available vaccine to these populations will be staggered and overlap. It will not be one group and the next, and so on. So coordination of the limited amount of vaccine with cold chain management and coordination of staffing and transportation is highly complex. but our experts, with help from the JFTN expertise, have developed a matrix to ensure that the plan is flexible and to be able to take account of weather or other complications that may arise. To ensure successful rollout, the GNWT will take a phased approach to vaccine distribution. So we know the first shipment arrived on December 28, 2020. The timing of subsequent vaccine arrival in the Northwest Territory is still being determined. Due to having additional vaccine delivery teams and utilizing local resources when appropriate, or available vaccines to the priority population will be staggered and overlap. So it will be not, again, one group to another. The phased approach allows the GNWT to remain flexible to respond to variables such as the timing and quantity of vaccine shipments, as well as other logistics, while working towards the goal of ensuring priority recipients are among the first to get access to vaccine. So coordination of a limited amount of vaccine, cold chain management, and coordination of staff and transportation is highly complex, but we will take into account and still maintain a plan that's flexible enough to take into account other weather or complications. We will continue to engage with communities and Indigenous governments on details about vaccine delivery and quantities as quantities are confirmed. So all eligible NWT residents who would like to be vaccinated will have access to the COVID-19 vaccine in 2021. And to ensure that all residents have this access, we are committed to the following actions. 1, deploy mobile vaccine clinics to all communities in Northwest Territories. To make the vaccines as accessible as possible, the Health and Social Service authorities are creating multiple mobile teams who will coordinate vaccine delivery to all 33 communities. They will support local healthcare staff in the immunization program. And the teams will stay in the community as long as it is required to ensure all those eligible have the opportunity to be vaccinated. Given that the Moderna vaccine requires 2 doses, mobile teams will return to the communities roughly 28 days later to administer the 2nd dose. All members of the mobile team will be from within the territory or will have completed the mandatory 14-day self-isolation period prior to traveling to the communities, as per public health orders. In order to support residents making informed decisions about vaccination and increase confidence in the vaccine, we will ensure residents do have enough time to have their questions and concerns addressed. Opportunities to engage residents before the mobile clinic staff arrive to the community will be prioritized. And in most communities, local health staff will be available to provide information before immunization clinics begin. Prior to the mobile team's arrival, a healthcare provider will engage with community leadership to address any misconceptions, hesitancy, and answer any questions. Translators and interpreters will be used whenever possible to ensure that information is written in plain language and available in Indigenous languages, using a variety of communication methods specific to Northern audiences. The goal is to support relationship building and trust by providing time and space for residents to make informed decisions. And in order to support vaccine uptake, all potential barriers that may prevent vaccination must be addressed. And this includes, but is not limited to, cost, convenient access to vaccine clinics, language barriers, and potential fear of contracting COVID-19. To ensure that each resident has access to COVID-19 vaccine, the GNWT will be offering the vaccine free of charge to all residents with support from the Government of Canada. And in cooperation with local government, community governments and organizations, the GNWT will ensure that residents with accessibility concerns will be supported to have access to vaccination. Additional barriers may be relevant to a specific community. To this end, vaccine clinics will be designed in consultation with local healthcare staff and community leaders who understand the needs of their communities best. If at all possible, people could adjust their schedule to be available to get the vaccine when the team comes to the community. That would assist greatly with the complexity of the overall rollout of the vaccine. But it will not be a one-time only opportunity to get the vaccine. If someone changes their mind or are not available as the nurses are in, the community or they have not heard from their physician to see if they can get the vaccine, every effort will be made going forward to have vaccine available to people in the future or when vaccine is rolled out for the general population. And finally, the last category, monitoring report. So we will have strong immunization surveillance systems because they're essential to monitor the safety and effectiveness of COVID-19 vaccine. Ongoing surveillance of real-world vaccine use is well established. It's a well-established part of Canada's vaccine system, and it is made of three main streams. The first is safety. We need to monitor if the vaccine causes any new adverse reactions or if adverse reactions are more severe or present more often. Coverage. We need to monitor the percentage of residents that have been vaccinated. Effectiveness. We need to monitor how well the vaccine works to slow disease transmission and reduce illness, death, and hospitalizations in uncontrolled real-life circumstances. So Canada's vaccine surveillance involves healthcare professionals, vaccine manufacturers, all provinces and territories, Public Health Agency of Canada, and Health Canada to alert public health authorities of changing trends or unusual adverse events that were not previously reported. Surveillance data provides the required information to adjust vaccination programs and to achieve a level of vaccine coverage that will slow disease transmission and ultimately decrease rates of illness, hospitalizations, and deaths. The objective, then, is to monitor vaccine safety, effectiveness, and coverage to inform local and national decision-making. The GNWT, in fact, have well-established reporting systems already used for other vaccine reporting. So we will continue to use existing vaccine reporting to monitor vaccine coverage and to help us understand how many residents have been vaccinated and how many are required to achieve herd immunity. Herd immunity means that enough people have been immunized, making the spread of specific disease between people less likely. The timely reporting on adverse events following immunizations and vaccine administration. So vaccines are closely monitored once distributed and be quickly removed if safety concerns are identified. So like any medication, vaccines can cause side effects and adverse reactions. After being vaccinated, it is common to have mild and harmless side effects. This is the body's natural response as it works to build immunity against the disease. It is also possible, but very rare, for someone to have a serious adverse reaction to a vaccine. The Canadian vaccine monitoring system includes federal, provincial, and territorial partners, and we rapidly share and disseminate information to appropriate stakeholders regarding vaccine safety signals or other relevant issues. Regulations within the NWT Public Health Act require timely reporting of any adverse events following vaccinations from all healthcare providers. Information is reported directly to the Public Health Agency of Canada from my office, and it contributes to national and international vaccine safety monitoring efforts. So finally, what happens next? So the availability and a rollout of a COVID-19 vaccine is a turning point in this pandemic. Emergence wisely stated that all public health restrictions may be lifted once a vaccine for COVID-19 has been approved, produced, and distributed to vulnerable populations. However, before any measures can be safely lifted, the vaccine needs to be delivered to as many people as possible, and the rate of infection needs to be reduced territorially, nationally, and globally. The national vaccine rollout, as well as the ongoing status of the pandemic across the country, is factored into the decision made about territorial public health restrictions. So over the coming weeks and months, as more research is completed and more COVID-19 vaccines come on the market, recommendations may support vaccinations for a greater proportion of the population. Changes to recommendations will happen once there is strong evidence of vaccine safety and efficacy. Finally, public health measures like travel restrictions, self-isolation requirements, and rules for gathering in businesses have been put into place to mitigate the health impacts of COVID-19. These measures have been instrumental in the protection of the public, but have taken a toll on residents of the Northwest Territories. The goal has always been to return to our normal way of life and remove these measures. Successful rollout of vaccine will be a major step in getting back to a normal way of life, but it will take time. Following vaccine delivery, the restrictions will be reviewed and adjusted to reflect the risk level. But it is very important to continue to do routine public health measures even after the vaccine has been rolled out. These actions, such as healthy respiratory practices, frequent hand hygiene, non-medical mask wearing, and physical distancing, may continue as routine health practices to help prevent COVID-19 and other respiratory diseases such as the flu and pertussis. It will be important to maintain these protective measures and continue the behaviors we have successfully adopted. It is good to remember that it's safer to get the vaccine than the disease, that even if you are not in a high-risk category, by getting the vaccine, you help protect those around you, your friends, family, elders, co-workers, patients or customers, and the community. The NWT has received 7,200 doses of the Moderna vaccine. An additional 4 shipments of the vaccine are expected later in January, February, and March 2021. The Office of the Chief Public Health Officer has categorized residents and staff at long-term care as among those at highest risk and priority for immunization. As such, these vaccines were rolled out on December 31st to residents and staff at the Jimmy Erasmus Seniors Facility in Baychurco and Avon's Long-Term Care Facility in Yellowknife, as well as the Stanton Extended Care Unit. The intent is to complete vaccines in all the long-term care facilities over a 2-week period. Community vaccination clinics and clinics targeting other priority groups will begin the week of January 11, 2021. Training is underway for nurses, logisticians, and support staff, so mobile teams can be deployed next week. Work is underway to confirm vaccine deployment to high-risk priority groups during the months of January and February. Vaccination teams are flexible to be able to deploy to communities based on factors like priority populations, weather, and ability to transport vaccines to ensure cold chain management. And the NTHSA website does identify current vaccine clinic location, dates, and times. It is up and running, and more information about future clinics will be posted as it becomes available. There will be ongoing updates for Indigenous and community leaders taking place throughout the rollout. Communication has developed vaccine information sheets translated in all but one Indigenous language and will be rolling explainer videos and updated websites. And these will be available both on the NTHSA and HSS websites for public and healthcare professionals. I thank you for your time this evening.
Yeah, Masicho, Dr. Kandola. We'll now do a round of questions, as I mentioned earlier, and with one question, one follow-up from each member. And before we get into it, I just want to ask that all the preambles, questions, and responses are short and to the point. Thank you. First member I have up is Emily Lafferty. Emily Lafferty, the line is yours.
Merci, Mr. Chair. I'd just like to say merci for the presentation. Because we all been looking forward to this. First question I have is obviously the 75% eligible population. So the remaining 25%, Dr. Kandola, I believe, mentioned that they will be covered within the 2021. So when is that going to be happening? Because I'm getting some questions on that as well for those 18 and under. When is that going to come into effect to be covered? That's my first question.
Let's show Emily Lafferty, Dr. Kandola.
So at this point, there are 2 vaccine distributors approved. They're Pfizer and Moderna. But there are other contracts that the government of Canada has with other pharmaceutical manufacturing companies. So there are vaccines being developed by AstraZeneca and Johnson & Johnson. And it is anticipated in the second quarter and subsequently that we'll have more vaccines available. So with the 25% of the remaining eligible adult population, should they choose to seek vaccine or want vaccine, that should be available. It's the aim of the government of Canada to have every Canadian immunized before the end of 2021. With respect to those under age 18, the Moderna vaccine manufacturer is currently conducting a clinical trial for children between ages 12 and under 18 And hopefully the results of that trial will be available so that if they are, the vaccine is just as efficacious in that population, they could be included as an additional population to vaccinate in the future. Other manufacturers are going even lower than age 12. Thank you.
Thank you, Dr. Condolo. Follow-up, Emily Lafferty.
Yeah, Mr. Chair, the vaccine, I noticed some elders got it in Béchacon and Yellowknife as well. Some individuals have not been vaccinated since they were born, so they're worried about the vaccination. I'm assuming that it's not mandatory, but so if these individuals do not get vaccinated, because they're asking me these questions where if we don't get vaccinated, are we going to be targeted? Let's say going to a theater. If we don't get vaccinated, are we still being allowed to certain areas? So I told them I don't have those answers yet, but we'll certainly get those answers. So those individuals that will be vaccinated, by all means, it's good on them. But there are others out there that will not get vaccinated. So just question of, I guess, how the process, how they're going to be treated down the road. I guess those are the questions that are being thrown at me, Mr. Chair. Merci.
Yeah, thank you, Emily Lafferty. Dr. Condolo, would you like to take that?
Minister Green?
Yeah, if you could direct the questions to me, that'd be great. The vaccine is not mandatory, and there are no plans to make it mandatory. However, there may be services that require the vaccine for people to be vaccinated in order to access services. So, or testing so that they can access services. So there may, in the end, be a difference between people who are vaccinated and those who aren't in terms of access to services going forward. So that is a risk. But at the same time, as I said, this is not mandatory. If people are not comfortable in the first round getting the vaccine, there will be subsequent times for them to consider getting that vaccine. And I'll ask Dr. Condolo if she would like to add anything to that.
Thank you, Mr. Green. Up next, I have Emily Bonridge. Emily Bonridge, the line's yours.
Merci, Mr. Chair, and merci to the ministers, CPHO, and the staff for appearing before us tonight in this all-important vaccine rollout. I had concerns about communications because according to the schedule, Fort Providence and Kakiza Enterprise and Katlodechi in my writing are slated for the 18th to the 31st, but one of the chiefs contacted Decho Health and they were told January 11th. So already we're having a miscommunication in your plan. And January 18th is fast approaching. I still don't see any notices, nothing in my communities, especially Enterprise, Kakiza, and Katlodechi. And Fort Providence is a larger center, but we don't have anything. And you all know my concerns about the health centers taking the lead role since the coronavirus started way back in March. And not a peep out of the health center all these months. And it still continues to operate in seclusion from the community. I'm wondering, given the timeline and the miscommunications already, how are you going out to communicate? Because I know already the indigenous governments have not been contacted at all, period. So I'm really hoping that you'd step up on your communications plan here and make do of it for the betterment of the residents, and get the communications out there, even on radio. Get the health centers to get on local radios and everything. Do it ASAP. Can you touch upon that, Masi?
Thank you, Emily Bonarouche. Ms. Green.
Yeah, thanks, Mr. Chair. I'm going to start, and then I'm going to ask Dr. Candola to continue, because quite a chunk of her presentation is about communications. So the week of January the 18th is about 10 days away, and it's my understanding that exact community dates have not yet been decided because of that need to consult. And so as a result of that, without a specific date, there is not any point in putting up posters or announcements on the radio and so on. It is the intention of the staff to finalize these dates and provide that communication as soon as possible. So that's how it's going to happen. And I will now ask through the chair for Dr. Candola to provide some additional detail. Thank you.
Thank you, Ms. Green. Dr. Candola.
So just to clarify, we have mobile teams right now. We have logisticians, and part of, before they go into the community, there has to be communication provided, and that operational rollout is under the Health and Social Service Authorities. So Dr. Pegg can expand more on that part, but what I wanted to reflect back to Emily Bonarouche is that when we look at these communities you mentioned, Fort Providence, Kakiza, Enterprise, KFN, these communities were strategically selected because they're border communities, and looking back from March, just the amount of traffic that goes through Fort Providence, this is a priority small community, just to let you know, and it's really important for us that they're among the after the cabin communities, the flying communities, that we have specifically have prioritized your community just because where it is on Highway 1. But before the team goes in, we have to communicate, and the mobile teams are part of that. And I'll just describe, other than the general communication, there will be targeted communication, and that, as Dr. Anne-Marie Peck can go into more detail on that. And
yeah, thank you, Dr. Candola. Follow up, Emily Bonarouche.
I thought somebody else was going to answer there.
Oh, sorry. My apologies. Dr.
Yes, hi. Yes, thank you, Mr. Chair. So that's actually very valuable feedback that you brought forward, because it does close a loop between how our teams are communicating, are planning to communicate, and the communication plan that's in place, and what seems to be the reality on the ground. So that's helpful feedback, and that will be fed back to the teams themselves. With regards to the concern about dates, the dates for the communities that you mentioned, you're right. It is mentioned for the week of the 18th to 24th on the website, and that will also be a follow-up point to make sure that the staff in the local health offices and in the health center are aware of that date, and they are aware to check that website, because it will be updated regularly. We have a number of different ways that we're interacting with communities, including community check-ins, which involve the health authority, the Office of the Chief Public Health Officer, MACA, and other regional and territorial authorities to help communities be prepared. And in fact, I was on a phone call with Fort Liard just today. So that also is helpful feedback to know that perhaps that communication isn't being passed amongst all of the different branches that need to be involved in this rollout. Communication is also taking place between the vaccination teams and the health centers to use existing resources with regards to clinic locations, times, and how to actually roll out the practicalities of that. And the teams are very keen to use the resources in the communities. So again, I thank you for your comment, and we'll be passing along that there needs to be perhaps a little bit stronger communication between the clinics and a more granular approach to how we're rolling out that communication plan. Thank you.
Thank you, Dr. Baig. Follow-up, Emily Bonner-Rush.
Merci, Mr. Chair. Yeah, merci for all that. I have to stress the importance of communications. You probably should have had a communications coordinator because there's nothing on the radio right now. You're going out on the 11th. That's just coming up in a few days. And nobody has radios for 2 days of the weekend, Saturday and Sunday. I don't know how you're working with the local health centers. We don't hear nothing here yet. Nothing. Like I always say, you always have the best laid plans, but they always are way late because of communication. And it's very important that we follow that. I also wanted to know if, as there's no health centers in some of the small communities in my riding, Kakiza, Enterprise, and Katlodechi, how will the message be communicated to them, and will the vaccine team go into these communities? I don't want to see our residents having to go into Hay River or Yellowknife to receive vaccinations. We want them to go into these communities. Merci.
Thank you, Emily Bonner-Rush. Minister Green.
Thank you, Mr. Chair. I'll turn this question over to Dr. Pei.
Yeah, thank you again for the question. With regards to the question about vaccination teams going into the very isolated communities, the answer is yes. Those teams will be going into those small communities to deliver vaccination in place. With regards to the communication in general, again, I agree that it is probably the most important aspect that's going to lead to success of this campaign. The week of January 11th is not January 11th, so there will be more specific dates forthcoming when we have an idea as to which communities will be visited on which day. And what I'm hearing is that we need to make sure that we're doing a good job at using multiple media approaches, not just a website, in order to make sure that people are informed. So thank you for that.
Thank you, Dr. Pei. So up next, I have Emily Johnson. Emily Johnson, line is yours.
Thank you, Mr. Chair, and thank you to Minister Green and her whole team. I know everyone's been working hard over the holiday season, and I'm happy. I think we're all happy that 2021 brought us the vaccine. My first question is on, I know moving into the next phase of Emerging Wisely requires kind of the curve down south in Canada to calm down, and similarly changing the borders. But to date, all the communications has kind of been, we're waiting for that, we're assessing the situation. Can I just get a somewhat of an estimate of when we could expect those changes? I have lots of constituents who run tourism businesses, and they want to know whether they should have a summer season or not. People want to know whether they will be going down south this summer. It affects our entire infrastructure and how we roll out our capital planning as well, as I'm sure you're aware. So I'm just wondering, is it safe to say that this summer, after we get to 75% vaccination, we can expect those restrictions to be lifted? Thank you, Mr. Chair.
Thank you, Emily Johnson. Minister Green, line's yours.
Yeah, thanks for the question. I'll ask Dr. Kendola to answer this one.
So in Canada, for the first quarter, which is January, February, March, the only jurisdictions in Canada that were given enough vaccine to vaccinate a significant part of their population was Yukon, Northwest Territories, and Nunavut, and we were given 75%, enough to do 75% of our adult population. So that translates to about 51,600 doses for NWT. Unfortunately, for the rest of Canada, they've only received about 5 to 10% of their vaccine allocation, and we're averaging about 7,600 cases per day right now in Canada, with over 625,000 cases to date. So for the rest of Canada, they're not going to achieve herd immunity or significant immunization for probably until the end of 2021. In the NWT, we have that ability to achieve a high immunization level. So some of the restrictions that we could see within the NWT as we approach March is that internally we can have more gatherings. We can move into a more of a phase 3 in the NWT. The other great benefit is that Nunavut and Yukon are also achieving huge adult immunity. So looking at their territories, and if they achieve enough adult immunity, you're going to see that their the ability of COVID to transmit or cause severity in the high-risk population will also be decreased at the same level as us. So there'll be a lot more comfort in allowing having more freedom of travel between the three territories. So that's in progression. Is I'm hoping that when we achieve enough immunization, that we have relaxed more gatherings internally, greater freedom territorially. But the struggle is that the rest of Canada won't be at that level, and we sort of still have to keep the travel restrictions. So people who are coming in and who are still riskless will have to do the 14-day self-isolation. But there could be greater movements in other areas as we move forward, as Canada increases their immunization and bends their second wave. There's one piece of science I'm still waiting for that is going to make a big difference, and that is, does the COVID vaccine, we know the COVID vaccine, getting it prevents the disease. Does it prevent the transmission of infection? Because if it prevents the transmission of infection, it means I get the COVID vaccine and there's no virus in my nose when I'm exposed, so I'm not giving it to you. But we don't know that yet. But that will make an incredible difference on how we can move freely if we're immunized, because then we know that we're not at risk for spreading it to others.
Thank you, Dr. Condola. Follow up, Emily Johnson.
No follow-up question. Thank you for that answer, and I look forward to both seeing that science and hopefully a territorial travel bubble sooner rather than later. Thank you.
Mr. Joe. Up next, I have Emily Simler. Emily Simler, line's yours.
Hello, can you hear me?
Yeah, go ahead.
Okay. Yeah, no, I just have a couple comments, and I just wanted to, we've known about that where we're going to get the Moderna vaccine, and I know that they're only going out now, and we're not doing any education. And I'm going to just do this I just want to say that we have very capable nurses. When we talk about cultural competency and cultural safety and cultural awareness, the nurses that we have that have been in our communities are probably the most cultural competent that we have without teams coming in. I think the teams coming in make it more of a colonial fly-in and make more fear. I think that the nurses that we have in my community and within our region are experienced and could have rolled this out, but without their input, which, that they never got the opportunity. I understand vaccine, and I understand the shipping vaccine, and I understand that it needed to be frozen, but it's going to get to the hospital here. Once thawed out, it's good unopened for 30 days. We have a great team of healthcare professionals and pharmacists in our territory that, I'm sure that could have rolled this out where we could have had vaccine already going out into the communities and the nurses could have been doing the education. So that's more of a comment. So because I know I've already asked the question about why they weren't involved. But my question is what is the cost of having the teams go out? Like, we have staff that are here that just finished off the flu vaccine, and it was our best flu vaccine year. We had no teams. And so I wanted to know, how is this different? And I understand that we can say this is gold. All vaccine is gold for us, And, I just wanted to make sure that this is the best way that we're rolling this out. If we have the vaccine and we're ahead of schedule, well, we could have been even more ahead of schedule and we could start to look at vaccinating others. And I mean, even the nurses in our community, they know who we say long-term care, but then they could move on to the next higher priority because they know who their clients are. We don't have to wait for the teams to come in and all these other things. Everything they'd have everything ready if they got to go ahead to do this. So that's going to be my question is, now they're going to have to fly back in and do the second doses. Can we reconsider if, our staff that are in the centers can do the second dose and we can just keep going so that way we're getting the vaccine out and that way we could move ahead of schedule and then we can start to, people have been in the territory, this time of the year. I just spent Christmas at home. It's first day of sun today. It's been dark, lonely, there's nothing open, and so we just want some freedom. Like, people want to start moving, and I get that we don't know if it's going to stop transmission, but the faster we get the vaccine into anyone who wants it, like the Yukon, then we can start moving ahead. And I know we got 7,200 doses. I heard the Dr. Condola, and we're receiving another 7,200 doses for the booster. And I'm hearing Ottawa, and I'm hearing all the chief medical officers saying, don't hold back doses, just give out vaccine. There'll be more coming. So is that a plan for us as well? So we could, if we decide we're going to move ahead faster, can we do that with the staff that we have? Thank you.
Let's show Emily Similar. Minister Green.
Yeah, thank you. Thanks for your question. I'm sorry that you're taking the planning which has been done by the department and the health authority as some kind of judgment on the competence of the staff. That is not the case. I'm going to say that again. That is not the case. I heard Dr. Candola say very clearly that the traveling teams will be working with local healthcare staff, recognizing that they have knowledge of their patients and circumstances. And so what I heard is that this is a combined approach. It is not a drop-in, drop-out approach. I want you to understand that it takes a total of 6 weeks to develop immunity. You have a shot, 28 days later you have another shot, and then you have 2 weeks to develop immunity. So even if we went to every nook and cranny in the NWT right now, we could not create immunity any faster than the current plan, because this is the timing of the administration of the doses and how long it takes for immunity to be created. I think some of your other questions are more operational, and through the chair, I would like to ask Dr. Pegg to respond to them. Thank you.
Thank you, Ms. Green. Dr. Pegg.
Yes, thank you, Mr. Chair. So I think the most important takeaway from this is that the teams who have been hired and the supplementary staff that we're using for this vaccination rollout are supplementary to the existing resource that exists in the communities, not replacing them. We want to get this done as fast as possible, as you have said. And while vaccination is rolling out, other health issues are going to continue in a lot of these communities. And people also need to be available to respond to those. We would like to pause everything and have everyone remain completely well while the vaccine rolls out, but unfortunately, there are still lots of things that need to be done. So the idea behind sending teams in to help with vaccination may not simply be the act of vaccinating, but to ensure that the staff who are there have the training to answer questions, because this is a new type of vaccine. So there's supplementary educational material that doesn't go along with other vaccines. And that there is an even greater vigilance around the cold chain. And that speaks to the additional reporting and surveillance requirements that have been put in place by Health Canada. They are potentially not that complicated for someone to learn, but they are different from the ones that we are already using. They're in addition to the ones that we're already using. They can be somewhat onerous, and the reporting schedule is frequent. So our teams are needing to make detailed reports to Health Canada on a regular basis in a manner that is taking up a significant amount of their time that would certainly eat into the time of staff who are already in the communities. So while we certainly want to absolutely capitalize on the expertise and the experience of particularly nurses in a lot of these communities, and it will, in many of the cases, be those nurses who are vaccinating alongside our teams, we also are cognizant of the fact that people need to be able to continue to access other healthcare services. And that's where that collaboration is going to come in. The other thing to look at in terms of vaccine rollout is that in the smallest communities, any eligible adult over the age of 18 will be offered vaccination during the first visit of those vaccination teams. So there ideally will be fewer visit needs to visit those smaller communities. In the bigger centers, we need to balance the use of the vaccine in as many people who want it, and the fact that we need to have enough vaccine before the next shipment arrives to vaccinate subsequent communities after the visit is done. And that is a technical challenge that involves a lot of math, and certainly we would like to be able to vaccinate everyone all at once and potentially leave vaccine for those who missed the first dose. But as these vaccine doses are so precious and the reporting requirements are as they are, the choice that has been made has been, at least for the initial rollout, to use supplementary, not replacement teams. Thank you.
Thank you, Dr. Pegg. Follow-up question, Emily Semler.
So my next question would be just if you get out to the communities then with these teams and you've vaccinated as many people as would take it, because we already know, we're hearing of the vaccine hesitancy, then the regional centers that are having the residents coming home and supposed to be isolating, who are more at risk, because when people aren't isolating, and we all know, we all come from, the ones that come from regional centers know that the people that go home not necessarily always stay home. So will that move faster than March for everyone else to start getting vaccinated if the small communities are done and the long-term care, and will they start opening up those vaccines for the rest of the population sooner than later? Thank you.
Thank you, Emily Semler. Mr. Green.
Yeah, thank you. As Dr. Candola said, the vaccine is scheduled to arrive in phases. So there are 4 phases of delivery for the vulnerable populations that spread from the 28th of December, which we've already received, to next week and on through January and February. It's my understanding that the bulk of the vaccines, the ones that will be used in the hub communities, will arrive in March. So the limiting factor around moving up the vaccine schedule is the delivery of the vaccines themselves. And that is not something that we have control over. Their procurement and distribution is being handled by Ottawa. So I hope we get ahead of schedule. That would be awesome. But there's no guarantee that means that we can then move up the regional hub vaccination plan. Thank you.
Thank you, Minister Green. Up next, I have Emily Jacobson. Emily Jacobson, line's yours.
Thank you, Mr. Chair. I'd like to thank Minister and the staff for the briefing, and this is an exciting time, I guess, for myself in regards to making sure that our communities that I represent in Nunavut and basically all the Beaufort Delta. I see your schedule, and I'm happy with it. I wish that we could, like when Minister Green was up here about a month and a half ago, I think it was already, and now we're talking about not like a travel bubble between the communities, because March, April is our community, or for our community gatherings. So we want to make sure that we're encouraging all of our people that's listening tonight and family members to take this, to get this COVID-19 vaccination done. So it's just because it's been, like Lisa said, it's been a tough year on everybody this last 9-10 months, and but I really am thankful for the way things are rolling out. I think you said we're about 2 weeks ahead of schedule, and I see your schedule. It's good, and basically it's just a comment and making sure that we're hitting our elders and the people that are traveling, that are sickly, and that are having to go back and forth for chemo, for cancer, and all this other stuff. And just making sure that the 14-day isolation that has to be shortened if it's possible once we start really getting this vaccine going and being done into the communities. Thank you, Mr. Chair.
Thank you, Emily Jacobson. Mr. Green.
Yeah, thank you. Emily Jacobson, I remember you saying when I was there how much you were hoping the vaccine would be delivered in time for people to attend the winter carnivals, and it looks like that is a possibility, so that's good news. Through the chair, I'd like Dr. Candola to talk about whether or when the isolation period might be shortened. Thank you.
Yeah, thank you, Mr. Green. Dr. Candola.
So I just wanted to reflect on Emily Jacobson's comment. When you look at the small communities like Tuktoyaktuk, and you look at my travel restriction self-isolation order, the biggest impact, the biggest burden has been on the small communities. With my public health order, we wanted to maintain isolation near the regional hubs. In the regional hubs where we have strengthened health capacity, which meant that people living in small communities had to spend 14 days in either Hay River, Fort Smith, Inuvik, Yellowknife. And so when you look at how we prioritize the vaccines, we recognize that these small communities are vulnerable, and we know that small communities that don't have health centers are particularly vulnerable in the flying-in only communities. And then we branch out to places like Tuktoyaktuk, because if you look at the orders, these are the people who bore the brunt of, unfortunately, the isolation, mandatory isolation in the hubs. So as we move through the vaccination throughout the next 3 months, and the second dose will go into April, and we're looking at the bending of the second wave, and we're looking at the vaccine uptake, and evolving science, it would allow more gatherings. It would allow us, when you look at our phase 3 gatherings, we actually have the differences. We allow more people to meet, and that information will be provided in the next 3 months. But what we also know is, again, it does impact the rest of Canada, so we still need to have travel restrictions for people coming in. But things can change around isolation requirements for people who are immunized, especially if we know that they don't transmit the virus. And so there will be a lot more easing of where people can safely isolate, and it may not need to be in the 4 hubs. Regarding the shortening of the isolation duration, that currently when we have 7,600 cases per day, the importation is too high. But in the future, as the number of cases drop, for those who don't have 2-dose vaccination, there could be an impact that combined with testing. So all these considerations and these relaxings will be something that we be looking as we roll out this vaccine program. But it also depends on how many people take up the vaccine. So considerations and more to be told in February, March.
Thank you, Dr. Gould. Just ask a reminder to members and respondents to keep your comments and preambles and questions short to the point. Thank you. Follow-up question for MLA Jacobson. Line's yours.
Thank you, Mr. Chair. Thank you, Mr. Candola. In regards to that being said, how many, I guess, if you're going to come in, I'm going to promote this right now to make sure that all my communities are hearing this, and potentially that, the more that we get done, the better. So making sure that your teams that are coming into the communities have enough vaccine. So when they're coming into the communities, will they have enough vaccine to vaccinate the community if possible? Thank you, Mr. Chair.
Thank you, Emily Jacobson. Minister Green.
Yeah, thanks. I'll ask Dr. Pegg to answer that question, please.
Thank you, Minister Green. Dr. Pegg.
Yes, thank you. That's a relatively easy one to answer because it's yes. The teams will have enough vaccine when they come into the communities to ensure that anybody who wants to be vaccinated at that time on that day will be able to be vaccinated.
Thank you, Dr. Pegg. Up next, I have Emily Simpson. Emily Simpson, the line is yours.
Thank you, Mr. Chair. I appreciate the briefing, and I guess I'm looking forward to the full vaccine rollout as well in the future. Right now, that what I hear in Hay River is there's a common theme, I guess, with the vaccine rollout is communication with those that are to receive it. In the presentation, I guess I heard discussion around trust and communicating information that is readily accessible and understandable. And we also talk about informed consent or making an informed choice by those who are about to decide whether they want that vaccine or not. In Hay River, we're, I guess, at extended care, we expect that to be started tomorrow. So I'm just wondering what communication has taken place with those in the facility prior to getting the vaccine, and do you believe that the information that has been, if you believe the information has been sufficient to receive that informed consent or for the person to make an informed choice? And also, have residents in a facility been given the opportunity to have a family member or caregiver with them when they are getting the information to understand what the process is? Because a lot of times what I find is that some people, they'll shake their head and say, yeah, I understand, but they might not hear you or they don't understand. So I just want to make sure that people do understand what's happening so that we can get as many vaccinated as possible. And also some I know that I've heard is that they requested that possibly a doctor be present or available to explain the process. And would that be an option for them as well? Thank you, Mr. Chair.
Thank you, Emily Simpson. Minister Green.
Yeah, thank you, Mr. Chair. These are operational questions, so I'll ask Dr. Pegg to answer, please.
Yeah, thank you, Mr. Green. Dr. Pegg.
Yes, thank you. You've touched on something that's very, very key, and that's the issue of informed consent and making sure that people are able to make the best decision possible. We've worked really closely with facility staff who have reached out to residents and have reached out to families. That happened in the long-term care facilities here in Yellowknife and Betchico, which were the first facilities where the vaccination was rolled out, in extended care, also here in Yellowknife. And we've been talking quite frequently with regional representatives to be in touch with health facility staff for the long-term care facilities in the facilities that are coming up for vaccination in the coming days. I can give actually an example that will be quick. Some of these facilities have a higher percentage of residents who are unable to give informed consent. And when we were speaking with regional representatives about the vaccine plan rollout, in some cases they actually asked us for more time in order to be able to take the time to sit with families and to explain the nature of the vaccine and the program rollout. And we've respected that request and have built in that extra time into our vaccination rollout plan. You also, I think, asked a question. There was a second part to that question.
Could there be a doctor present?
Oh, yes. So in some places, that's maybe more realistic than others, but to have a physician present throughout the vaccination activity is not part of the plan. However, for patients, residents who are living in these long-term care facilities, there has been a physician who has reviewed the medical records for the people living in those facilities and determined whether or not they would be eligible to be vaccinated, and in some cases consulted with specialist physicians regarding health conditions that some of the residents and some of the medications that they're taking. So there's definitely been physician involvement, and nurses have been trained in emergency procedures and are perfectly capable of reacting in the event of an emergency. Thank you.
Let's show Dr. Paik. Follow-up question, Emily Simpson. Okay, I'm not hearing any. Okay, moving along. Oh, sorry, go ahead, Emily Simpson.
Sorry about that. Yeah, communication is very important, and I've heard concerns over the last couple of days from family members of residents, and I just want to make sure that each person has that opportunity, because to know what's going on, because some of them do not have any family, some of them may not understand, so we just got to make sure that's done properly. The other question I have is for Hay River, how many doses of the vaccine are going to be made available for us, I guess, tomorrow? Like, how many people will we be able to vaccinate while the team is in town? Mr. Chair.
Thank you, Emily Simpson. Minister Ray.
Yeah, thank you for the question. I'll ask Dr. Peck to answer that. Or she might need to get back to you. Let's see what happens.
I can give you an inexact answer. So the long-term care facility in Hay River is scheduled to receive vaccination for residents tomorrow. I'm just double-checking that. Yeah, Woodland Manor is on the schedule for tomorrow. I am not aware of the number of residents in that facility, but the teams have been in touch with facility staff and will be arriving with an adequate number of vaccinations for residents, for staff working in that facility. A number of buffer doses will also be there in case of untoward circumstances where something happens with one of the vaccine vials, etc. And what I also want to make clear in this type of situation is the teams are not leaving these communities with vaccine. So if there is leftover vaccine at the end of the day, that would be the time where the teams are liaising with health staff in the community or in the region to find other vulnerable people who may be eligible for vaccination, so that the teams are not leaving with those vaccine doses. So that might be a front-facing staff member, that might be someone who's getting ready for medical travel, but we are not leaving the community with vaccine.
Yeah, thank you. I'm just going to add, Mr. Chair, that last Thursday when the Avens group was vaccinated, a friend of mine who's 95 received a call from one of the nurses, and the nurse said, "We have one dose left in this bottle, so could you come and get vaccinated right now?" And so she did. So the great thing about that is that no vaccine was wasted, and she was able, the 95-year-old was able to respond quickly to the call to go and get vaccinated. And she would obviously at 95 have been a priority candidate for vaccine anyway. Thank you.
Thank you, Minister Green. Yeah, thank you for that information. Interesting story. Up next, I have Emily Knockleby.
Thank you, Mr. Chair. Thank you to the department for the presentation. My question is going to come back to, I think it's page 5 of the plan, where you discuss the groups that are not recommended for the vaccination, which includes the immunosuppressed and the immunocompromised. Several of my constituents, including myself, are immunocompromised, and I believe that this is a discussion for me to have with my doctors. So. And others do as well, and they would like to know more about the risk assessment that will be placed for individuals, or is it a blanket no, and that people will not be able to get it if they do have certain pre-existing conditions? Thank you.
Thank you, Emily Knockleby. Minister Green.
Yeah, thank you for that question. I'll ask Dr. Candola to respond.
So the National Advisory Committee on Immunization, which is the expert body, when they had recommended that the immunocompromised or the ones with autoimmune disorders, or those who are pregnant and breastfeeding, and thus need to be excluded, not because it's just to say they don't have data on those particular populations. And the recommendations have been is for people who are immunocompromised or have autoimmune disorders, have a discussion with your specialist, And so what we're seeing is we're having, what I've seen is specialists have had discussion with the patients and have say, in your scenario, we recommend that you get the COVID-19 vaccine. And that vaccine will be provided. It's just have that discussion first about weighing the risk and benefits, because we don't have data on that. But I think in a matter of time with these specialized populations, that data will come. And it's just so we don't know if it's as efficacious or lower or higher, but that data will come. Meanwhile, if you want the vaccine and your physician supports it, you will get the vaccine.
Thank you, Dr. Cavilla. Follow-up, Emily Knockleby.
Yeah, thank you. Yes, that was my question, is whether or not we would still be able to get it if we had when we had that discussion with our doctors. My second question has to do with whether or not any positions within the GNWT regarding staff, whether or not they're going to be tied to having the vaccine and keeping their jobs. So I guess in other words, will people lose their jobs if they just decline to have the vaccine? Thank you.
Thank you, Emily Knockleby. Mr. Green.
Yeah, thank you. My understanding is that the vaccine is not mandatory, and so there are not lost employment prospects for people who don't get vaccinated. But I think for this question, I'll call on the Deputy Minister. He is probably better informed than I am on this. If I could, through you, call on the Deputy Minister, Mr. Chair.
Yeah, thank you, Mr. Green. Mr. Cooper, the line is yours.
Thank you very much, Mr. Chair. No, the Minister is correct. The vaccine is not mandatory. There would be responsibility of any employee who has contact with the public to follow, who chose not to get the vaccine, to follow employer-provided and normal precautionary measures in the event that they chose. This is the approach we currently follow, and so the key here is that we want to give people the information so that they can make an informed choice, but it will be a choice. Thank you.
Thank you, Mr. Cooper. Follow-up, sorry, that's a question answered. My mistake there. Up next, I have Emily O'Reilly. Line is yours.
Thanks, Mr. Chair. Thanks to everybody for the work over the holidays. And I do understand that this is a strategy, not a plan, but I think the expectations of the public are for a lot more detail. I just, and I note the importance of communications, as mentioned by several other MLAs. The vaccine schedule is not even found on or linked in any way on the general COVID GNWT website. That needs to be fixed. It's not even easy to find on the NTHSSA website. It's buried in the COVID update section. You got to find this information. People have to be able to find this information a lot more easily. But the kind of questions that I'm getting are people in Yellowknife want to know exactly how they're going to sign up or be offered the opportunity to get a vaccine. I can tell you for the flu vaccination, which I've gotten, you went in, you booked yourself a slot in a prearranged website. It was pretty user-friendly, but how are we going to make sure that the priority people, are they going to have to phone into a place to get a booking for a vaccination, and how is this going to work? How are you going to screen people to make sure that they're one of the priority groups? And because this is the kind of level of information people want to know now. Thank you.
Thank you, Emily O'Reilly. Minister Green.
Yeah, thanks. Certainly we'll take back these comments on making the information about the schedule higher profile so that it's easy to find. And with respect to how priority populations are going to be determined in Yellowknife, through the chair, I'd like to call on Dr. Pegg to answer that question. Thank you.
Thank you, Minister Green. Dr. Pegg.
Yes, thank you. So the thing that comes out of your question certainly is that not every community will have a sign-up and will have the rollout of the vaccination in the same way. So something that works very well for Yellowknife, like an online sign-up form for time slots, will not likely work as well in some of the other communities, which is why we're leaving it up to some of those smaller communities as well as the bigger ones to find a way that works best for them based on successes that they've had in the past, like you mentioned for the flu clinic. You mentioned Yellowknife and the online sign-up, and that's very likely what will be used for some of the bigger centres, whereas some of the smaller centres will rely on a more direct form of communication. In terms of determining priority groups, there will be a public call-out, particularly in the bigger centres, when vaccination is ready to roll out for those priority groups, and what constitutes a priority group will be publicly communicated. So, for example, diabetics, people with renal disease, people with liver disease, that will be included in the public communication. And we're relying on people to self-identify for these. There's not going to be a need for validation from your physician. We don't want to overwhelm the clinics with people requesting letters of authorization. We're relying on the public to self-identify as someone who falls into a priority group. If you're not sure, by all means, please feel free to contact your primary care provider or your health center to have your questions answered. We're also calling on people to be honest. And I don't think this would be a time where anyone would potentially pretend to be diabetic, but it is a moment. We've been exceptionally population-minded throughout the duration of the pandemic, and it's the reason that we've had such success in keeping our numbers low. This is a moment to remain community-minded and to let those people who are at higher risk for severe disease get vaccinated first. And again, as we've said multiple times, there will be enough vaccine for those who want to be vaccinated after. So in summary, the sign-up plan or the rollout of vaccine is going to depend on the communities and the priority groups in places where there will be multiple layers of vaccination rollout. Initially, those people will self-identify. Thank you.
Thank you, Dr. Big. Follow-up, Emily O'Reilly.
Thanks, Mr. Chair. I appreciate the response, and I guess there is a statement in the vaccination strategy along the lines of, working with communities to make sure that residents with accessibility concerns will be supported to have access to the vaccination. So I understand that this is going to have to be tailored to meet individual communities' needs and so on, but am I reading this right in that it's going to be as flexible as a home visit? Somebody who cannot make it to a school or a central place in a community where vaccinations are happening, and if they are, one of the priority groups, that they are going to have the ability to have perhaps somebody visit their home to deliver a vaccine to them if they can't make it to a central location. Is that what I'm reading into this sentence in the strategy? Thanks, Mr. Chair.
Thank you, Emily O'Reilly. Minister Green.
Yeah, thanks. I'll ask Dr. Pegg to answer that question.
If there is no possible way for a person to come to a vaccination site, then the vaccine will go to that person.
Okay. Thank you very much.
Okay. Thank you. Up next, I have Emily Marcellos. Emily Marcellos, the line is yours. Emily Marcellos, just check your phone, make sure it's not on mute. Okay. I'm not hearing anything from Emily Marcellos. Oh, there you go. Okay, good to go. Go ahead, Emily Marcellos.
Okay. So, Chair, I would like to wish you and all my colleagues a very happy New Year, and especially our guests tonight, Mr. Green and Dr. Candola and the team. I just want to make a short comment. The short comment is that I think many of us should be very grateful to be living in the Northwest Territories. Everybody in Canada is jealous of the Northwest Territories and the way this whole pandemic era has passed and is coming to an end, hopefully in 2021. I think that the Northwest Territories favored above everybody else in Canada. And I want to thank the Minister on behalf of all her team, including our hero, Dr. Condola. The people of Fort Smith are very grateful, especially the seniors. And all the people of Fort Smith always say that they just feel really safe with who's running the show in Yellowknife on behalf of the people of the Northwest Territories. With that, I want to ask two questions. One of them is, if a person gets both the vaccine, the initial and the booster, and they have to travel outside the territories for a medical, would the self-isolation time be shortened after the 75% are done? That was one of the questions that was asked by different people in the community.
Yeah, thank you, Emily Marcellus, Minister Green.
Yeah, thank you, Emily Marcellus, for your acknowledgement that this is a very safe place to be. The evidence bears that out. In terms of whether having both doses will enable easier travel in and out of the territory, I'll ask Dr. Condola to respond to that. Thank you.
Yeah, thank you, Minister Green.
Yeah, so the one piece of science that I'm waiting for that will hopefully, because it will take about 6 weeks to achieve full immunity with the 2 doses. One piece of science I'm waiting for is that if someone is to be vaccinated, I do know it has a good efficacy. Does the person still acquire the virus and then pass it on? If the person who's doubly vaccinated is protected well, and when exposed to COVID virus doesn't pass it on, then that will impact significantly their need to self-isolate when they travel out.
Thank you, Dr. Condola. Follow-up, Emily Marcellus.
So does that mean it'll be a shorter period, Mr. Chair, like possibly 6 days or less? Or I just want to make that clarification, because 14 days is a long time when especially some of the people that have to go out every month for treatment and they come back, and then 14 days of isolation even after we get the vaccine seems a bit much. So I just want to know if that's going to change.
Thank you, Emily Marcellus. Minister Green.
Yeah, thank you, Mr. Chair. Through you, I'll ask Dr. Condola to answer this question, please.
So if the evidence, which should come because people will be tested, if someone who gets the 2 doses of COVID vaccine, if the science shows that they don't transmit the virus, we know that the science shows they don't get the disease, but the science shows they don't transmit the virus. It's not a matter of shortening the isolation, it's a matter of, do they actually need the isolation, and can we manage with self-monitoring and just a confirmatory test is to avoid the whole period of self-isolation for that particular population. If you're not immunized, and if you're not fully immunized, you still have to self-isolate. So that is the question. By the time we reach the second dose, 2 weeks after the second dose, we're looking at 6 weeks. I'm hoping in 6 weeks that question can be answered through science and through the monitoring surveillance.
Okay, thank you, Dr. Condola. Up next, I have Emily Cleveland. Emily Cleveland, the floor is yours.
Thank you very much, Mr. Chair, and thank you very much to the team for their time this evening. I know it's late, and I know it's been a very long year for you all, so I appreciate your time tonight and your work throughout the year. My first question is a follow-up question from one of the questions posed by Emily Assembler. During her questions, she was asking about using local staff in order to facilitate the delivery of the vaccine in communities. And in the response, Dr. Pegg mentioned that there would be a training component and an educational component as the team of nurses is traveling throughout communities in order to deliver the vaccine. So I'm wondering if, because it is a 2-dose vaccination process, if the idea is that the team that originally goes in and delivers the dose and provides that education and works with local staff, if then the local staff would be able to administer the second dose to alleviate the need for travel into communities and coordinating a team to go in and do that, and perhaps be able to then leave behind trained staff that can take it from there. Thank you.
Thank you, Emily Cleveland. Mr. Green.
Yeah, thank you for your question. What I heard is that part of the reason to have traveling teams is to ensure that other health services are continued even while people are busy vaccinating the people who are coming forward for it. But to provide more detail on this through you, Mr. Chair, I'd like to ask Dr. Pegg to respond.
Thank you, Minister Green. Dr. Pegg.
Yes, thank you. Minister Green has touched on one of the key reasons that we have used supplementary staff, and that is to ensure that health services are able to continue during the vaccine. And after the first dose is administered, particularly if there have been a lot of doses administered over a short time, it is likely still going to be most effective and the best use of resources if there is a team that goes back and is able to administer that second dose, again in a short period of time, to make sure that the maximum number of people are able to be vaccinated within the window to ensure that the immunity is maximized. The other thing that we don't expect to change is the reporting and surveillance requirements that Health Canada has laid out, which, as I mentioned, are particularly onerous and required with a lot of frequency. And again, we're hoping to avoid exponentially increasing the workload for staff in communities. What we are looking at probably being able to use our staff for even more is once those nurses have information about the vaccine and about the mechanism of action and how the vaccine works, will be to be able to continue the education efforts that happen in between visits of the teams, the vaccination, that those nurses will act as resources, and that those nurses may in fact be able to deliver vaccine as the rollout continues once those priority populations and the initial 75% of the population has been targeted. Thanks.
Thank you, Dr. Pegg. Follow-up, Emily Cleveland.
Thank you very much, Mr. Chair. Mr. Chair, my second question starts with a comment, and I'm happy that MLA O'Reilly brought up the issue of needing to dig for information on the vaccine within the NTHSSA website. What I'd like to ask through the minister is that kind of a government-wide website takeover, in that every government department really since COVID is a GNWT-wide thing and an NWT-wide thing, and that information on vaccines should be available everywhere, is that every website has a feature card that links to the vaccine information. So regardless of whether or not people are on social media or tuning into local news, that they have every opportunity to be able to access that information, I think is really vital. But my question is specific to the vaccine itself, and one of the questions that came in from a constituent was, as much as people try to wash their hands and try to stay socially distant and protect themselves, people still get sniffles and they still get coughs and strep, and we see reports of whooping cough and whatnot. So if anybody is exhibiting symptoms of any kind at the time that the clinic comes to their community or is open to them, does any type of symptom prevent them from being eligible to get the vaccine? Thank you.
Thank you, Emily Cleveland. Minister Green.
Yeah, thank you. First of all, thank you for your suggestion about possibly putting a link on all the websites so that people can more readily access the information. That's something that we'll follow up. And then in terms of health status prior to vaccination, through you, Mr. Chair, I'd like to call on Dr. Pegg.
Thank you, Minister Green. Dr. Pegg.
Yes, thanks for the question. The question regarding health status and eligibility for vaccination is going to depend on a couple of factors, notably that person's individual risk profile for having COVID. So if someone is potentially at high risk of having acquired COVID, so someone who's still in the 14-day isolation period, for example, or someone who has recently had contact with someone who's been diagnosed with COVID, if they were symptomatic, that person would not be eligible for vaccination. They would be instructed to continue to follow isolation requirements. They would be tested for COVID, and if the test was negative, they would be offered vaccination at the next available opportunity when teams are returning to that place, if it's an isolated community. And obviously, if the test is positive, there would be medical treatment and follow-up done for that person. With regards to someone who may be in a lower risk category, so someone who doesn't have any exposure risks, who is ill, that would be a decision made by the healthcare provider at the time of vaccination. Typically, someone with a high fever or with other symptoms of severe illness would be not eligible for vaccination at that moment. But someone who is at very low risk, who has low risk symptoms, would likely be offered vaccination. Thank you.
Yeah, thank you, Dr. Big. And I have the last question. I have only one question, I guess, and a quick comment. And I just want to say, thank you to all your staff, Minister Green. I mean, we're going to see one of the biggest, largest logistical rollouts of any kind in our history, from a medical point of view and for any other sort of operation. And it's going to take all of us to work together. I think it's all starting to slowly come together, and I think it's a matter of really communicating well with each other and teamwork and all that. But I guess listening to most of the questions I was going to ask were already asked tonight, but I did have one that wasn't quite touched upon, and there was some mention about doctors not being on site for all the inoculations that are going to be taking place. So I know that with any sort of I don't want to call it a foreign substance, but any sort of new substances that you're administering, there's going to be some adverse reactions. So with that. My question is, are there any known contraindications, and precautions that one need to be aware about with this Moderna vaccine? Thanks.
Thank you for that question, Mr. Norn. This has been a popular question about the possibility of having an adverse reaction. What we know so far is that it's extremely unlikely, but that doesn't mean it can't happen. And so for more detail on this, I'm going to ask Dr. Pegg to weigh in, please. Thank you.
Yeah, thank you, Minister Green. Dr. Pegg.
Yes, thank you. So as Minister Green mentioned, the risk of an adverse reaction from the vaccine is extremely low, but not zero. It's significantly lower than complications related to COVID, which I think is an important point to keep in mind. At this point, the only absolute contraindication to receiving the Moderna COVID-19 vaccine would be an allergy to any component of the vaccine or a previous reaction to that vaccine. Now, you're probably asking, how would I know if it's never been administered before? So obviously, someone who has a reaction in the first dose, there would be a significant risk-benefit discussion before they receive the second dose. And additionally, on the Moderna product monograph, which is the guide to the vaccine product itself, there is a list of the components of the vaccine. And some of these are used in other vaccines as stabilizers to make sure that the vaccine is able to get into our cells and do its job. And some of those components of the vaccine have been known to cause allergic reactions. So for anyone who has had a serious adverse reaction to a vaccine before, it's a good idea for that person to get in touch with their healthcare provider and see if that was felt to be related to one of the components of the vaccine. Furthermore, all of the nurses will be doing a risk assessment at the time of vaccination, and if there is a concern about a potential risk of allergies, that vaccination would likely be deferred. And the final aspect is that nurses who are vaccinating are trained in response to emergency procedures and response to reactions. And people who do have a history of a serious reaction outside of any of the components of the Moderna vaccine are going to be requested to remain under observation for 30 minutes as opposed to the standard 15-minute period as an extra precaution following vaccination. Thanks.
Yeah, thank you, Dr. Pegg. I'm just going to read something out to you, Mr. Norn, from the National Advisory Committee on Immunization. It says there's one possible allergen known to cause allergic reactions that's listed in the product monograph. It's polyethylene glycol, and this product can be found in bowel preparation products that are used for colonoscopy, laxatives, cough syrup, cosmetics, contact lens care solutions, skincare products, and as an additive for some food and drinks. So if someone has a history of a serious allergic reaction to any of these products, they should consult their healthcare provider to confirm whether it's a good idea to receive the vaccine. And I think that we can post this information in the FAQs so that people can go back and look at it at their leisure. Thank you.
Thank you, Minister Green. I don't have any other questions, so with that, I guess I'll want to thank you, Minister Green. Thank you for taking the time to answer our questions. I know a lot of the public and a lot of people did have a lot of questions, and I think we've addressed a good chunk of them tonight. And with that, we're going to be taking a short break, but before that, I'd like to have a motion to go in camera. Members, we have a motion to move in camera. Emily Cleveland. Any objections? So with that,
Could someone disconnect?
I'd like to go into camera, and we'll take a short break.
Okay. Thank you. See you later.
Thank you.
Happy New Year.
Happy New Year.